The ability to open an airway and to ventilate a patient with a bag valve mask apparatus are skills that frequently save lives. To effectively manage the airway, you must be able to assess your patient's respiration, open the airway, manually assist your patient's ventilation, and stop ventilation when it's safe to do so. Let's review the anatomy of the larynx. The larynx is a muscular tube in the neck that contains the vocal cords. It's the uppermost opening to the tracheobronchial tree and lies anterior to the esophagus. The larynx functions as a sophisticated valve that lets us breathe air, cough effectively, and swallow food and liquid without aspirating. Vibration of the vocal cords lets us vocalize sounds. The laryngeal skeleton gives the larynx rigidity and support. It is formed principally by the hyoid bone and the thyroid and cricoid cartilages. Attached anteriorly to the inside of the thyroid cartilage is the epiglottis, a curved, leaf-shaped structure. Its upper, rounded edge projects into the pharynx just behind the tongue. The stalk at the base of the epiglottis allows it to swing up and down over the laryngeal opening, covering and uncovering it like a trap door. The depression between the epiglottis and the tongue is called the vallecula. The vocal cords are ligaments that project forward from the arytenoid cartilages to the inside of the thyroid cartilage. The opening to the trachea, called the glottis, lies between them. The ability to breathe effectively and to carry out the other laryngeal functions depends on coordination of many muscles. The glottis normally widens during inspiration and narrows during expiration. This dynamic control of airflow reduces resistance to breathing with both faster inflow and outflow of air as effort demands. The harder you try to breathe, the wider the larynx opens. Because of the structure of the larynx at any given glottic opening, there is more resistance to inspiration than to expiration. For this reason, conditions causing airway obstruction, such as edema or tumor, usually produce symptoms with inspiration before expiration is even impaired. Protection from aspiration also depends on muscle coordination. During swallowing, the whole larynx rises in the neck, the epiglottis folds over the glottis, and the tongue and pharyngeal muscles direct food and liquid backward into the esophagus. When muscle tone is lost, the epiglottis, tongue, and other pharyngeal tissues fall backward, blocking the larynx and obstructing breathing. A good example of this from everyday experience is snoring. Early recognition and treatment of respiratory compromise is essential. Under normal conditions, breathing room air, the average human body cannot store much oxygen. Apnea for more than about a minute can lead to a severe lack of circulating oxygen. Permanent brain damage can occur after as little as 3 minutes, and death will inevitably ensue after a few minutes more unless ventilation is restored. Once respiratory arrest progresses to cardiac arrest, outcome is poor. This patient is recovering from an uneventful general anesthetic. Her level of sedation and her morbid obesity put her at increased risk of airway obstruction. Despite the distractions, watch how her care team stays focused and continually reassesses her status. The anesthesiologist evaluates breath sounds, vital signs, and oxygen saturation. Her saturation is lower than normal. Her blood pressure is high. She's breathing slowly and shallowly. When she develops partial airway obstruction, they intervene quickly to open her airway. They then reevaluate her breathing. It's adequate, so they don't need to assist her breathing, but she can't hold her own airway open without assistance. Ultimately, they administer the narcotic reversal medication Narcan to treat her respiratory depression. As the patient's mental status improves, she breathes more deeply and maintains her own airway. Her saturation improves, and her vital signs return toward normal. In cases like this, close observation, early recognition of airway obstruction, and appropriate treatment of the underlying condition act to prevent potential airway emergencies. A normal resting tidal volume is about 8 millimeters per kilogram of lean body weight, regardless of age. However, this can mean a big difference in tidal volume, from 40 milliliters for a 5 kilogram baby, 160 milliliters for a 20 kilogram toddler, or 800 milliliters for a 100 kilogram man. To compensate for their much higher metabolic rate and higher oxygen consumption in the face of such small tidal volumes, the infant or toddler must breathe much more rapidly than the adult. The range for a normal respiratory rate for an infant 30 to 60, for a toddler 24 to 40, for an adult is about 12 to 16 breaths per minute. Infants and children are especially vulnerable to respiratory failure because they have little cardiopulmonary reserve. To breathe effectively, the intercostal muscles and diaphragm contract, increasing chest volume and lowering intrathoracic pressure. Air is pulled into the lungs through the unobstructed airway. Normal elastic recoil of the chest wall then increases intrathoracic pressure and pushes air and carbon dioxide out through the unobstructed airway. The chest rises with inspiration as the lungs expand and falls with expiration as the lungs deflate. Meanwhile, the heart constantly contracts, returning non-oxygenated blood to the lungs to pick up more oxygen and sending oxygenated blood back out to the rest of the body. With good cardiac output and lung function, oxygen delivery meets oxygen demand, and carbon dioxide is eliminated from the body as it's produced. Many things can disrupt the respiratory system and cause it to fail. Hypoxia or inadequate blood oxygen content and/or hypercarbia or high blood carbon dioxide can easily occur due to a variety of circumstances. Altered mental status due to medications, underlying illness, or trauma. Upper airway obstruction, such as snoring, sleep apnea, foreign body, or swelling. Lower airway obstruction, such as asthma or emphysema. Impaired diffusion of gas from alveoli to capillaries, from such things as pneumonia, tumor, radiation, or burns. Abnormal pulmonary blood flow from shock or heart failure from any cause. Chest wall or diaphragmatic injury from broken ribs or ruptured diaphragm. Impaired chest wall and lung motion from such things as extreme obesity. And impaired nerve or muscle control, such as spinal cord injury, paralytic drug effect, muscular dystrophy, or stroke. Evaluate your patient using 4 criteria: their effort to breathe, including rate and depth, mechanics of breathing, color of mucous membrane and skin tones, and cardiovascular response. A patient who is able to maintain adequate oxygenation only by using extra effort to move air and by increasing the breathing rate is in respiratory distress. The degree of distress can be mild, moderate, or severe, and is often accompanied by an increased heart rate or tachycardia. How hard is your patient working to breathe? When severe hypoxia is present, the conscious patient with respiratory distress usually exhibits air hunger. He or she appears anxious and breathes rapidly. Non-specific signs of hypoxia and poor ventilation include restlessness, confusion, agitation, tachycardia, hypertension, or sweatiness. Unfortunately, it's easy to be fooled into treating disorientation caused by hypoxia or hypercarbia with sedative medications and unintentionally precipitate respiratory decompensation. Always consider hypoxia and hypercarbia when treating disoriented patients. The faster and more deeply a patient breathes, the more turbulence in the airstream. If upper airway obstruction is present, stridor, a high-pitched, harsh, creaking, inspiratory sound is produced as air moves past a swelling or constriction of the laryngeal structures. This is how stridor sounds. Laryngospasm, croup, and epiglottitis are examples of conditions causing stridor. The patient who is able to sit up should be assisted into the position most comfortable for breathing. The patient may want to assume the tripod position, leaning forward with their outstretched arms on their knees. This maximally opens the airway and allows full descent to the diaphragm. This position is especially common in children with respiratory distress. A patient who, despite extra effort and increased breathing rate, is unable to maintain adequate oxygenation or who has poor oxygenation is in respiratory failure. As respiratory failure worsens, the patient will start to decompensate. Respiratory rate may actually slow and effort will decline. In the patient exhausted to the point of respiratory collapse, or in the patient with respiratory depression due to altered mental status from any cause, there may be little effort to breathe. Hypoventilation worsens hypoxia and hypercarbia, both of which increase sedation and further depress respiratory drive. The patient with respiratory depression can become apneic with little warning. Snoring is very common in the patient with respiratory depression. Snoring occurs when the soft tissue at the back of the throat collapses over the larynx, causing partial or total obstruction. During sleep, a snoring person may rouse himself to relieve the obstruction. However, a patient with altered consciousness or one with sleep apnea may not. When there is little air movement, you may not be able to hear bronchospasm, stridor, or snoring. Partial upper or lower airway obstruction alters the mechanics of breathing. Let's look at another patient to see some of these physical signs of obstruction. This 7-year-old girl is about to undergo tonsillectomy for enlarged tonsils. She's breathing in anesthetic gas. As she loses consciousness, her muscles relax and she starts to obstruct her airway. Watch how the mechanics of her breathing changes. When a patient is working hard to breathe, the accessory muscles of respiration, the sternocleidomastoid and scalene muscles, tends to lift the clavicles and allow fuller expansion of the chest. These muscles become tense and rope-like. Look how the skin over the tracheal notch is sucked inward, an important sign of obstruction. The harder the patient tries to breathe against both upper airway or lower airway obstruction, the more negative pressure is created inside the chest. This pressure differential sucks the soft tissue between ribs and the sternal notch inward. When the diaphragm descends maximally, it pushes the abdominal contents downward and outward, further decreasing intrathoracic pressure. If the airway is obstructed, no air can enter the chest, and this negative pressure pulls the chest wall inward. A rocking chest motion occurs, with the chest falling and the abdomen rising. This motion is the opposite of normal inspiratory motion. Other signs of airway obstruction can include poor movement of air in and out of the mouth and nose, nasal flaring, faint or absent breath sounds, head bobbing or grunting, and the inability of the awake patient to phonate. The provider opens the airway by pulling up on the jaw, then inserts an oral airway. Look at the difference in chest wall motion now that obstruction is relieved. Another important criterion is the color of skin and mucous membranes. Cyanosis is the bluish coloration of mucous membranes and skin due to deoxygenated hemoglobin in the blood vessels near the skin surface. It occurs when arterial oxygen saturation falls below 85%. The bluish skin color associated with cyanosis is a late and sometimes unreliable sign of hypoxia because ambient lighting, skin pigment, and severe anemia make it hard to see. An oxygen saturation monitor is much more reliable if you have one. Normal oxygen saturation is 97 to 100% on room air, corresponding to an arterial PO2 of about 100 millimeters of mercury. Be especially alert if your patient's oxygen saturation falls below 90%, corresponding to an arterial PO2 of 60 millimeters of mercury. These values provide the minimum oxygen delivery to prevent metabolic acidosis and will fall quickly below these numbers. You may need to maintain a higher saturation if the patient is anemic. As oxygenation falls, the body compensates by activating the sympathetic nervous system in an attempt to maintain oxygen delivery to the major organs. For adults and older children, hypertension and tachycardia develop. For the patient with marginal cardiac reserve, this can increase the risk of heart attack, heart failure, and stroke. With prolonged and severe hypoxia, the cardiovascular system ultimately fails, and bradycardia develops. At this point, cardiac arrest is likely unless hypoxia is relieved. In infants and young children, however, things are very different. In children, bradycardia may be the first sign of hypoxia, not the last, because their sympathetic nervous system is immature and easily overwhelmed. A slow heart rate delivers less oxygen. Cardiac arrest can occur within minutes. Always assume bradycardia in a child means hypoxia and treat the child with oxygen and improve ventilation until proven otherwise. Look, listen, and feel for air movement. If air movement is poor, then stimulate the patient. When simple arousal doesn't improve the airway, then you must open the airway yourself. The following maneuvers assume no cervical spine injuries. If cervical spine precautions are needed, use jaw thrust only and maintain a stable head and neck position. With the head in a relaxed and flexed position, the tongue and soft tissues tend to collapse over the larynx and cause obstruction. The oral, pharyngeal, and laryngeal axes are not aligned. The optimal positioning for ventilation or for intubation is the same and starts by placing the external ear canals level with the chest. A folded sheet or towel under the head of a patient older than 2 years aligns the pharyngeal and laryngeal axes. A child younger than 2 has a relatively large occiput. Placing the towel under the shoulders in this age group is often more effective. Tilt the head back. Pulling the angles of the jaw upward puts tension on the base of the tongue and soft tissues and lifts the epiglottis off the trachea, aligning all the axes. There are several ways to open the airway of a patient who is breathing spontaneously. Most common is the head tilt chin lift maneuver. Tilt the head backward, place your fingertips under the rim of the mandible, and lift upward, keeping pressure on the bones, not the soft tissue. Pressing on the soft tissue potentially obstructs the airway, especially in small children. The heel of your hand applies counterpressure against the side of the face. To use the jaw thrust maneuver, grip the angles of the mandible with both hands and pull upward. This frequently pulls the head into extension. Pressing on the bone 1 to 2 centimeters above the angle of the jaw and below the ear is painful and may help rouse a sedated patient enough to breathe on their own. If you're using cervical precautions because of potential cervical spine injury, pull upward only on the jaw, keeping the head and neck stable. The triple airway maneuver combines the previous techniques. Tilt the head into extension and lift the angles of the jaw. Use your thumbs to pull the mouth open. While it's easy to pull the mandible upward by placing your thumb in the patient's mouth to grip the chin, it's potentially dangerous because the patient may bite you. Look, listen, and feel for evidence of good ventilation. The chest rises and falls appropriately with breathing. You should hear breath sounds. There is good movement of air in and out of the mouth. A clear oxygen mask fogs with each breath. End-tidal CO2 is present. If obstruction persists, the next step is to insert an oral or a nasal airway. An oral airway is a fairly firm, curved piece of plastic, which sits on top of the tongue and pulls it and the associated soft tissue forward, away from the top of the larynx. The correct size puts the flange outside the teeth and gum line and positions the tip near the vallecula. To estimate the correct size, place the oral airway next to the patient's jaw and judge where the tip will lie. Too short pushes the tongue back over the larynx, worsening airway obstruction. Too long extends outside the mouth and interferes with mask fit. There are several ways to insert an oral airway. Open the mouth as wide as you can. Insert the airway with the curve toward the tongue and slowly advance it until its tip slips behind the back of the tongue. If necessary, place a tongue blade towards the rear of the tongue to pull it forward. Some oral airways are flexible. When using a flexible airway, you can grasp it firmly in your right hand and force it to straighten as much as possible. Place the straightened oral airway on a tongue blade and slide it down the blade and into position. You can also invert the airway's curve towards the roof of the mouth. Advance it until it lies behind the tongue and then flip it into position. Use caution to avoid tooth damage or mucosal injury. Oral airways, although very effective, have potential complications. A conscious or semi-conscious patient may fight your attempt to place one, risking both tooth damage and provider injury. Stimulating the gag reflex can cause vomiting with possible aspiration. Incorrect placement pushes the tongue back and can actually increase obstruction. It can also compress lingual vessels and nerves, causing swelling or tongue numbness. In addition, the tip of the tongue can get pinched between the oral airway and the lower teeth, producing bleeding or edema. Nasal airways are often better tolerated in the semi-conscious or conscious patient because they stimulate the gag reflex less. Nasal airways are soft, flexible tubes which slide through one side of the nose. This positions the opening of the tube in the posterior pharynx behind the tongue. The opening is often, although not always, in line with the trachea. Choose the largest size to comfortably fit your patient. Coating a nasal airway with water-soluble lubricating gel or water makes insertion easier. A local anesthetic gel is best because this also numbs the nasal passages. Avoid plugging the tube with gel. Direction of insertion is very important. Don't thread the nasal airway upward towards the frontal sinus. Instead, advance it along the floor of the nose, perpendicular to the plane of the face. Advance slowly and carefully. Don't force it if you hit an obstruction, because the nasal airway could tear one of the turbinates. Instead, gently rotate the nasal airway to allow the tip to slide around any obstacles. Choose a smaller size or try the other side if necessary. A long nasal airway can stimulate the epiglottis. If coughing or gagging occurs, slowly withdraw the nasal airway a centimeter or two. Insertion of a nasal airway can cause a nosebleed. In the anticoagulated patient, use with caution or not at all. After opening the airway, check your patient's ventilation. If the patient still isn't breathing well, you should immediately assist or control his respiration. Mouth-to-mouth ventilation is one option if you don't have specialized equipment. Here, we'll discuss the use of a bag valve mask apparatus. There are different types of bag valve mask devices. Here, you will see ventilation with either the typical Ambu type bag or with an anesthesia machine circuit demonstrated. Select the correct size mask for the patient. When you squeeze the bag, the gas will take the path of least resistance. A good mask fit seals against the contours of the patient's face and forces the gas into the patient's lungs, expanding the chest. The wrong size mask prevents a good seal, allowing gas to escape and making it difficult to inflate the lungs. Open the airway. If there is no risk of cervical spine injury, also pull the head into extension. Don't flex the head forward, which could increase airway obstruction. Most masks have a rounded triangular shape. The apex of the triangle fits over the bridge of the nose and covers the space between the top of the nose and the crease in the chin. The entire upper and lower lips fit inside the mask. Lower the mask over the cheeks and allow the edges to grab the bunched cheek tissue. The bulk of the cheek now fills the gaps between the mask and the patient. Make sure the lower lip is inside the mask. Note the final position of the fingers. The thumb and forefinger press the mask against the face and form a C shape. The remaining fingers grip the bony mandible, pull upward, forming an E. The mask seal is created by the opposing force of the thumb and index fingers pushing down against the force of the last three fingers pulling up on the bony mandible. Don't press on the soft tissue under the chin, because this can increase airway obstruction by pushing soft tissue down over the laryngeal outlet. Most people maintain the mask seal with the left hand and ventilate with the right, because the usually dominant right hand can do more of the physical part of squeezing the bag. Protect the eyes. It's easy for the mask to push open the eyelids, exposing the eyes to corneal abrasion. Consider taping them closed if the patient is unconscious. To ventilate, squeeze the bag. The chest should rise with each breath. Pay attention to the resistance you feel as the lungs inflate. Obstruction makes squeezing the bag more difficult, whereas a leak in the ventilation system makes squeezing the bag very easy. In both these cases, however, the chest won't rise well. When in doubt, have a helper listen to the chest as you ventilate. You should hear breath sounds. Although there are some medical conditions where breath sounds are hard to hear, the absence of breath sounds almost always means inadequate ventilation. If an end-tidal CO2 device monitors the patient, you should see evidence of exhaled CO2. Always use the least force required to effectively inflate the lungs. Too large a tidal volume risks pneumothorax, especially with children. Slow, steady inflation is usually more effective than rapid, jerky puffs, because the gas is more likely to expand the chest and less likely to distend the stomach. Stomach distension pushes the diaphragm up into the chest cavity, impairing lung inflation and increasing the risk of vomiting and aspiration. Allow the patient to exhale between breaths. Keep your own hands in a relaxed position if possible. If your fingers spasm, you will lose fine motor control and may have difficulty maintaining a seal. Relax slightly for the few seconds it takes for the bag to refill. If you have a good mask seal, little or no air will escape around the mask. You can tolerate some leak as long as you can ventilate the patient. If you don't have a good seal, then you must get a better fit. Typically, the leak will be on the side with the bag, opposite the hand holding the mask. To make it better, rotate the ventilation bag attachment to change the point of maximum pressure. Reposition your hands if necessary. If you have an assistant, ask him or her to push the cheek up against the outside of the mask at the leak sites. Some patients are more difficult to ventilate than others. In edentulous patients, the lack of teeth allows the cheek tissue to sag unsupported, leaving large gaps around the mask. In the obese patient, an extensive double chin and full cheeks can make it hard to grip both the mask and the face effectively. Airway obstruction from pharyngeal soft tissue is common. In addition, the weight of the patient's chest may force you to use higher inflation pressures, which can distend the stomach. Trauma patients may be particularly challenging because parts of the face may be injured or even missing. Foreign bodies, such as broken teeth, may be present and need to be removed, and there may be bleeding. This makes it hard both to apply effective pressure to maintain a mask seal, as well as to keep the airway clear of secretions. The help of an assistant in any of these situations can be highly effective. You can often get a better seal by leaving both of your hands on the mask and having a helper squeeze the bag for you. Place thumbs on top of the mask. Place fingers on the bottom, bunching the soft tissue of the cheeks under the mask. Use your fingers to hook the bony mandible and pull it upward. When someone else is squeezing the bag, it's especially important to watch the chest rise and listen to breath sounds to verify adequate ventilation, since you can no longer feel the compliance of the bag yourself. Make sure your helper communicates any signs of obstruction or lack of seal to you immediately. This technique is a team effort. The condition causing the respiratory failure may make manual ventilation challenging. For example, congestive heart failure, seizure activity, pneumothorax, and bronchospasm can all make breath sounds faint, chest inflation poor, and airway resistance high. You must treat the whole patient, not just help them breathe. If you can't ventilate adequately with a bag valve mask device, you may need to insert a laryngeal mask airway or intubate the patient. Sometimes you may need to assist the ventilation of a patient who is breathing spontaneously in order to improve their tidal volume. Gently squeeze the bag just after the patient starts to inhale. The airway is most open at that point and the resistance least. The breath you deliver should continue to expand the patient's chest for the few seconds after he stops inhaling. Always allow the patient to exhale. If you squeeze the bag during exhalation or coughing, the gas will simply take the path of least resistance to enter the stomach or exit around the mask. Coordinate your efforts with the patient's own breathing rhythm and time your squeeze for the start of the next inhalation. It's safe to stop ventilating the patient when he or she has an adequate tidal volume and respiratory rate to maintain good oxygenation and ventilation. Patients will often tolerate an oral or nasal airway fairly well until they're awake enough to hold their own airway open. It's easier to leave it in place until then, rather than remove it too soon and try to put one back into a semi-conscious patient who might fight you. The patient will often recover enough to breathe on his own before he's awake and aware enough to protect himself from aspiration. Always be prepared for possible vomiting. If you can't ventilate using a bag valve mask device, you may need to consider inserting an LMA or intubating the patient. The ability to manage airway obstruction and to ventilate the patient with a bag valve mask device are essential skills in patient management. Early intervention can and does prevent problems and improve outcomes. Mastery requires experience. Practice at every opportunity.